Good afternoon, doctors, and welcome back to the plenary hall. We will now begin with session 5 on cerebroprotection in stroke. To introduce the speakers is our moderator. She is a distinguished vascular neurologist recognized for major academic and clinical contributions in stroke care. She is the chief resident in adult neurology training in the University of the Philippines, Philippine General Hospital, and is the immediate past president of the Stroke Society of the Philippines. She also led the establishment of the stroke unit at the Baguio General Hospital. She is a past president of the Philippine Neurological Association and an active leader of the Stroke Society of the Philippines, Philippine Neurological Association, and Asian Stroke Advisory Panel, an advocate for advancing stroke care nationwide. Ladies and gentlemen, let us all welcome our moderator, Dr. Maria Socorro Sarfati.
Thank you for that introduction. Good afternoon to our esteemed colleagues and distinguished guests. Welcome to the 5th and final session of our convention. Okay, we have saved the best for last. Tama ba yun? Okay, so this session on neuroprotection on stroke will explore evolving strategies from cooling techniques to molecular therapies, conditioning approaches, and repurposed treatment. All would aim to safeguard the brain and improve outcomes for patients. Our first speaker gave several interesting talks since yesterday. A highly respected leader in neurology and psychiatry. He earned his medical degree from the University of Santo Tomas Faculty of Medicine and Surgery, completed his residency training in neurology and psychiatry in the same institution, and currently serves as chairman of the Department of Neurosciences and Behavioral Medicine at UST Hospital. He heads the stroke unit and neurointensive care unit at Chinese General Hospital and has held leadership roles as past president of the Philippine Neurological Association, the Philippine College of Psychopharmacology, and the Stroke Society of the Philippines. He also serves as the vice president of the Asian College of Neuropsychopharmacology. We are honored to welcome back on stage Dr. Johhny Lokin, who will present the lecture entitled Neuroprotection in Stroke, From Cooling to Cutting-Edge Molecular Therapies. Our second speaker is a board-certified vascular neurologist and fellow of the Philippine Neurological Association. She's a member of the Philippine Academy of Vascular and Interventional Neurology and the founder of the Acute Stroke Unit at Our Lady of Lourdes Hospital under Metro Pacific Health. She's also a researcher and lecturer on neuroprotection and neurosonology, and serves as one of the members of the Board of Directors and Board of Trustees of the Asia Link Group of Companies and ROL Foundation. Please welcome on stage Dr. Stephanie Patricia Badillo, who will deliver the lecture on conditioning the brain, harnessing ischemic pre- and post-conditioning for stroke care. Our third speaker represents the new generation of vascular neurologists. He completed his residency in neurology at the University of Santo Tomas Hospital, followed by fellowship training in vascular neurology at the same institution. He is currently Assistant Training Officer at UST Hospital, serves as part of the medical staff of Veterans Memorial Medical Center, and is a visiting physician at Jose Reyes Memorial Medical Center. He also teaches as an assistant professor at the UST Faculty of Medicine and Surgery. We are privileged to hear from Dr. Gabriel Alejandro Baroque, who will present his lecture on repurposing common therapies, everyday agents with neuroprotective impact. As a reminder, throughout the lectures, a QR code will be flashed on the screen. We encourage all attendees to scan the code and send in your questions, and this will be entertained during the open forum after all lectures have been delivered. And now, to begin the session, may I call on our first speaker, Dr. Johhny Lokin.
Okay. So, good afternoon. So, I think this is my first lecture na hindi ako magda-drug pushing, okay? But I think this topic may probably become an interesting topic once again after you will hear what I have to say about neuroprotection, okay? We went through a series of, controversies about neuroprotection or neuroprotective agents and cerebroprotection in the last couple of years because of the paucity of results which actually we could not translate into something that we can apply in terms of practice guidelines. No? Okay? So again, some of my very young colleagues here would again talk about neuroprotection. Okay? And again, going back to when we began all of this, I think it has changed somewhat in terms of what we know about neuroprotection. Okay? So it's now something that is aimed at preserving the structure and function of neurons and the neurovascular unit. And in terms of stroke, usually it is limited to ischemic stroke injury. But if you look at the targets, it has now changed to multiple components. Okay? That's why we wanted to change that term neuroprotection because we are not protecting just the neurons, but the other cells that I think Dr. Ana Nolido discussed a while ago. So we have to look not just into the neurons, the glial cells, okay, your oligodendrocytes, okay, your white matter, endothelium and blood-brain barrier, and the neurovascular unit as an integrated system. Neuroprotective agents or cerebroprotective agents would unlikely be successful if we just look at certain targets. And that is one of the Waterloo of most of the clinical trials and most of the drugs that we are using right now. Na hindi sila ma-convert into something that has stronger evidence. So this is the term now we would like to introduce, cerebroprotection. So again, we avoid the mistake of driving therapies to protect specific cells like neurons. Instead, we want to protect the brain. After all, we are mostly neurologists here. Okay? And again, this has gained a momentum now towards cerebroprotection rather than just looking at it as a neuroprotection. So here, I think if you listen to Dr. Nolido, she discussed all of this. So I'm not going to talk much about this. But again, in the perspective of stroke, after having a stroke, you are not only looking at the recovery of the neurons, but the whole package, even the pericytes, even the oligodendrocytes. So if you look at neuroprotection, it's actually a time-dependent and phase-specific. You can hyperacute phase, You have acute and subacute phase. These are very old concepts, no, that we have not really looked into in the past few years. No? If you look at the book of Cohen, he actually mentioned this, no, and that book was published around 1997. Okay? So we were very young then. Some of you are probably in elementary. No? Okay? So again, it is not supposed to replace now with the more popular reperfusion therapy. Okay? As I've said yesterday, no, when I talked about tenecteplase, just like in cardiology, they don't use a lot of IV thrombolytic treatment because na-overcome na sila ng intervention. On the other hand, tayo naman, hindi na natin masyadong maisip saan pupunta yung IV thrombolysis kasi andyan na yung thrombectomy. But in reality, even the whole morning we were talking about mechanical thrombectomy, okay, for reperfusion, marami pa rin naman hindi nakakapag-afford ng thrombectomy. Okay? So again, it should be an adjunct to thrombolysis and thrombectomy. Diyan ngayon nabubuhay ang research ng neuroprotective agents or cerebroprotective agents. A strategy to preserve ischemic penumbra. So, reperfusion is different from saving the penumbra. Diba? Okay? And of course, a bridge towards neural repair and neuroregeneration. So, again, neuroprotection should not be viewed as a single therapy. It is a multimodal approach targeting dynamic and evolving injury cascade, which is attendant to patients who suffer from stroke, ischemic stroke in particular. So here, why do we still need cerebroprotection after the publication of the SSP guidelines in 2024? Diba? Lahat doon, negative, no, not recommended or should be used carefully. Reperfusion will not be the same as tissue survival. Ongoing ischemic cascades after recanalization still occur, and you still have a penumbra that remains to be salvageable. Okay? So functional outcome is still limited despite what you have heard this morning about how powerful endovascular therapy can be. I'll show you some data later on. So again, if you look at the evolution of neuroprotection in stroke, you can look at very early phase, 1980s up to the year 2000. Yung mga nag-experience nito, wala dito lahat, no? Medyo inaantok na, iba nagdala ng mga bumalik sa room para mag-nap, yung iba nagchichismisan dyan sa labas sa booth, no? Okay? Pharmacologic neuroprotection is became very popular, no? There were so many neuroprotective agents that came into fore in these decades, and of course, dumating ang reperfusion therapy, okay, when the new approach, which is thrombectomy, showed positive results. And now, what I am also tasked to look at is the molecular network-based neuroprotection, which I think has a high potential, no, to give us probably something to look forward to. Okay? So let's look first at era number 1, no? 1980s to 2000. Cooling is not a new concept, no? If you look at this, Thomas Willis, okay, described the first, recovery from cooling, in 1650, by Anne Green, who was charged, with wala pang parang parricide, kasi her son died, and nung time na yun, crime yun. So she was sentenced to be hanged. And when she was executed. But lo and behold, winter time yon, okay? Binaba siya, tinanggal yung noose, nabuhay siya. Inalagaan siya ni Thomas Willis. So that's one of the earliest recorded, effect of hypothermia. Okay? So if you look at cooling, it's the first broad-spectrum neuroprotective strategy. Again, it is multifactorial, and again, it acts on multiple levels. Okay? So, right now, I think cooling has also been part of our ACLS, di ba? So, slowly, it has lost its popularity kasi pag nag-ACLS, pag meron ng return of spontaneous circulation, nakakalimutan ng tawagin ng neurologist. No? Okay? But That's why yung hypothermia na part ng ACLS, hindi masyadong nagagawa. No? And again, if you look at Peter Safer, who's the father of CPR, no? Yung kanyang paper, hindi ABC lang eh. It was A until I. No? Yung H doon was actually hypothermia. Okay? Now, if you look at how hypothermia protects the brain, these are probably the mechanisms, the postulated mechanisms. Alam natin, theoretically, nangyayari yan. No? Mukhang marami dapat na targets, multimodal. No? We try to simplify it and we come out with this particular slide. No? So you have so many targets actually, no? For neuroprotection in terms of cooling or hypothermia. So kaya in terms of neuroprotection, aside from cooling, kahit pharmacologic neuroprotection, medyo challenging talaga. Okay? So these are the early techniques. You can see the one in the right lower panel, inabutan pa ni Dr. Robert Gunn sa Columbia, no? Okay? So yung binabalot lang sa katawan, no? Okay? And of course, you also had other ways. Now before this, they used refrigerators, no? If you look at the neurosurgeons, ang mga unang na gumawa ng cooling technique, no? Dinidikit nila sa refrigerator, pampa-reduce ng ICP sa mga may tumors pag hindi nila operahan, no? That I think one of the famous surgeons who did this was Temple Fay. Okay? And of course, these are the more modern techniques, no? But ngayon, ang ginagawa nila is selective brain cooling, endovascular cooling, invasive na siya, transnasal, napakasakit, no? And pre-hospital cooling. But despite all of these fancy approaches, no? The problem is same, no? They cannot translate it into a positive clinical trial for stroke. Okay? Laging mas lumalabas yung mga complications ng cooling. Okay? So despite the evidence, no, that we try to push for hypothermia, hindi siya nagtra-translate into a very, very clear positive result. Okay? So why did hypothermia fail in acute ischemic stroke? Again, initiation is often too late relative to ischemic cascade. Systemic complications probably outweigh the intervention. Pneumonia, no? Shivering, okay? Hemodynamic instability. So again, it's difficult to integrate your cooling technique with thrombolysis as well and thrombectomy. No? Medyo magkakagulo yung flow, no? ng pathway natin. So hypothermia failed clinically, not because it was ineffective biologically, but because it was difficult to operate. Okay? Now, era number 2, pharmacologic neuroprotection. Ito, napakadami natin ito, no? Okay? And if you look at this, no? Again, rapid advances during these decades, identified multiple therapeutic targets, excitotoxicity, calcium overload, oxidative stress, inflammation, and apoptosis. And again, habang tumatagal, dumadami yung possibilities and theories, no? Approaches to GABAergic agents, free radical scavengers, anti-inflammatory drugs, okay? Calcium channel blockers again. And again, we keep saying more than 1,000 agents were studied preclinically. Maganda, but we are waiting for them to be positive when they are given to patients with stroke, okay? So unfortunately, ang problem dito was a lot of times it was the era of single target intervention in a multi-pathway disease. Okay? So these are just some of the evidence na ang dami, no? May neuroprotection, explosion ng neuroprotective agents during those times, no? And the clinical trials, marami rin. Ngayon, wala tayong masyadong nakitang clinical trials sa neuroprotection kasi lahat EVT. Okay? Lahat thrombolysis. Okay, so if you look at this, no, yan, no, napakadami, no. Some of them were even held, no, in our country, yung mga clinical trials na yan, and nothing really showed any positivity. Okay, I think uric acid, Dr. Baroque would be discussing part of it, no. Now, why did pharmacologic neuroprotection fail? Again, one, there are two arms, no. One is the disease complexity. Okay, again, it's a network injury, not just one single area. Okay, and you have a core versus penumbra heterogeneity. Okay, and of course, ischemic cascade is dynamic, and it can advance, and multiple overlapping mechanisms: excitotoxicity, oxidative stress, inflammatory response. And if you look at the current neuroprotective agent or cerebroprotective agent that we are using, lahat yan pwedeng ipasok dito sa multiple overlapping mechanisms. And of course, trial design flaws were also quite difficult. Okay, there was really poor external validity of animal models versus human acute ischemic stroke patients. No? And inadequate CNS penetration and drug delivery issues were also quite common. Okay, so in the failed era, again, the biological lessons there is we look at stroke as a network disease. Okay, injury can evolve over time. Neurons alone are not the only target. And clinical lessons, critical timing, delivery matters, reperfusion status matters, patient selection is also very important. So again, neuroprotection failed not because the concept was wrong, but because the approach was largely incomplete. No? If you have heard, I think Tito Obet mentioned this before in one of his talks, around 10 years ago. Kailangan multiple targets. Hindi pwedeng isa lang. Okay? And I think that holds true because andun yung Holy Grail. No? You have to be able to reach as many targets dun sa ischemic cascade to actually expect an outcome that would probably be positive. Okay? So here, ito, sikat na sikat itong mga drugs na to. Citicoline, edarabone, cerebrolysine, and MLC 901. But if you look at the results, parang laging bitin, We sometimes call it neutral, we sometimes call it slightly positive, pero kasi incomplete talaga yung effect ng mga medications na ito. Okay? Now, because of the controversy ng guidelines, I would rather you read the Clinical Handbook of Stroke Management in the Philippines because I think it shows you na andun yung mga evidence that these 4 drugs that are available can actually be used in our clinical practice. Okay? So, ayan, nandyan sa Japanese guidelines, pero wala sa Philippine stroke guidelines. Ang edaravone, for example, okay? Ang cerebrolysine, andyan sa European Academy of Neurology guidelines, Add-on treatment should be prioritized in moderate to severe strokes. Okay? Nandun din sa Austrian guidelines, rehabilitation guidelines, Canadian best practices. Okay? Nandun sila. Pero wala sa SSP guidelines. Okay? And here you have, ito, citicoline. Asa may evidence sa citicoline? Ito. Yan, Okay? This is part of the 2022 Spanish Society of nasa emergency medicine siya. Wala siya sa stroke guidelines sa Spain. Nasa emergency medicine siya. And they actually included citicoline as a part of the treatment of patients with stroke. Okay? So you can read that sa textbook ng Clinical Handbook ng Management of Strokes in the Philippines. Era number 2. Ito, reperfusion era. Okay? 2015, Okay? Nung lumabas yung trial coming from Netherlands, okay? Yan. Naiwan na ngayon ng IV thrombolysis, ng neuroprotection. Okay? So again, thrombectomy revived actually the concept of neuroprotection. Kasi ngayon, sinasabi nila, despite establishing reperfusion, you can have reperfusion injury. So how do you protect these patients at risk of reperfusion injury? It would be likely na baka merong role ang neuroprotective agents. So, lumabas ngayon is as an adjunctive therapy siya. Okay? So, EVT recanalization, you heard this morning, very high for large vessel occlusion, and of course, it became standard of care. It actually was transformative in terms of how we now deal with patients with large vessel occlusion leading to ischemic stroke. Okay? Pero this is their clinical reality. Recanalization, 80%. But functional dependence or independence is less than 50%. Okay? So, reperfusion does not mean functional improvement totally. Okay? And again, hindi naman nawawala yung mortality despite successful reperfusion. Okay? So hindi ibig sabihin ng 100% or 80% reperfusion will equate to a good outcome. It still depends on the patient, the risk factors, the comorbidity present in a patient. Okay? So opening the vessel, remember, does not guarantee saving the brain. And these are the major reperfusion injury mechanisms. Marami din. Dito ngayon pumapasok ang neuroprotection or cerebroprotection. Okay? So again, the brain remains vulnerable after reperfusion. Okay? You can look at all these post-reperfusion brain injury. Pwede magkaroon ng oxidative burst, edema, microvascular no flow, okay? Blood-brain barrier disruption, hemorrhagic transformation. Yun ang lagi natin naisip, hemorrhagic transformation, no? But there are others. And of course, inflammatory amplification. Okay? Now, why neuroprotection reemerged? I think si Dr. Baroque, love na love itong re-emergence of ng neuroprotection during the reperfusion era because he showed me one of those slides, no? From the American Stroke Association. Recanalization restores blood flow, drug delivery, access to penumbra in a patient who had reperfusion therapy, whether it's thrombolysis or thrombectomy. Okay? So, merong synergistic effect ang neuroprotection and reperfusion. Okay? So, nandun yung therapeutic window for neuroprotective agents. Okay. So, what makes reperfusion era different from the failure era? Sa reperfusion era, meron kang reliable reperfusion, either thrombolysis or thrombectomy, improved access to penumbra, imaging-guided selection, adjunctive, not standalone neuroprotection, and more biologically rational combinations. But remember, it's not standalone neuroprotection. Most of our patients with stroke, hindi naman na-thrombectomized. Most of them are not large vessel occlusion strokes. So how do we treat them? Ganda ng coat mo, Muksa. Change outfit ka. Okay. Okay. So if you look at this, no, adjunctive neuroprotection in the reperfusion era, well, I'm not going to talk much about normobaric hyperoxia. I think what I'm more interested in would be the targeted therapies. No, I'll give Dr. Gab the nirenitide portion, okay? But I probably focus on edaravone plus dexbornial plus your PSD95, okay? So again, modern neuroprotection should be multimodal and adjunctive, okay? I'll skip this kasi 8 minutes na lang, you know? So if you look at edaravone in the reperfusion era, we know that it helps in oxidative injury, okay? Especially after revascularization. This has been, you have seen publications like this for this biological attractive as an EVT or thrombolysis adjunct. Current interpretation, mixed clinical signals, but still one of the most plausible hospital-based supportive adjuncts is edaravone, okay? And edaravone fits the reperfusion era because it targets one of the dominant consequences of reoxygenation, which is oxidative injury. Okay? So, if you look at the other adjunctive, makikita mo, no? Pwede, no? Yung minocycline, I leave it to Gab again because you see, promising but inconclusive. Cerebrolizing is actually there, no? Mixed, more recovery-oriented than hyperacute rescue. Okay? So, I'll skip this. Okay? So, how to think about reperfusion era neuroprotection clinically? Again, we have to balance benefits and risks in large vessel occlusion treatment that leads to stroke. Okay? We have to look at high-risk patients and ideal candidates. Hindi, one of the comments is, hindi lahat kasi kailangan natin i-thrombolize or i-thrombectomize. We really have to look at the characteristic, no, of the patient. Okay? So this would be the key lesions, key lessons, naging lesions tuloy, from reperfusion era. EVT solved the access problem, not the biology problem. Okay? Good angiographic reperfusion does not guarantee good tissue outcome. Adjunctive neuroprotection is now biologically more plausible. And again, best candidates given early multimodal, image-guided, combined with reperfusion. Okay? And the era paved the way for targeted molecular therapies. Okay, now we go to cutting-edge molecular therapies. I'll try to go fast. If you look at the multifaceted targets of molecular therapy, under yung synaptic scaffold proteins, intracellular signaling hubs, mitochondrial pathways are also involved. Pwede ring target siya, immune phenotypes, and neurovascular unit biology. So we have to target more than the calcium channel blockers, more than the NMDA receptor. So if you look at era 2, single-targeted, poor CNS penetration, no perfusion, so you'll see that the outcome would not really be positive. Okay? Or pwedeng close to positive, neutral, okay? And of course, in era of reperfusion, mechanism-specific, or molecular targets, mechanism-specific targeting, okay? And reperfusion-coupled therapy. Okay? So neuroprotection is no longer, remember, a standalone strategy. It is an integrated precision approach. So here are some of the networks that probably would help us, but in the interest of time, I would try to look at stroke as a network-level disease. We are looking at the neurons, glial cells, endothelium, and immune system. And that would be the best targets for cerebroprotection or neuroprotection. Okay? So modern neuroprotection will aim to preserve physiology while selectively interrupting pathologic signaling. So hindi natin idadama yung mga good parts ng patients na nagkaroon ng stroke. Okay? So one of the most promising would be your PSD95, your postsynaptic density protein 95, okay? The axis of with NMDA and your neuronal nitric oxide synthase. So again, the traditional view is, block natin ang NMDA receptor para walang excitation, excitotoxicity. So NMDA receptor is essential for normal synaptic transmission and neural plasticity. Okay? But the modern strategy is actually to target PSD95, which is a scaffolding protein located in the PSD excitatory neurons, and disrupt coupling between your NMDA receptor and your neuronal nitric oxide synthase. So you now reduce your nitric oxide toxicity, which is a byproduct of your ischemic cascade in patients with ischemic stroke. Okay, so mitochondrial hub, alam natin, mitochondria, energy center. So they will have ATP failure, okay, reactive oxygen species generation, and later on leading to apoptosis. But therapeutic strategies now will have mitochondrial antioxidants, stabilization of membrane potential, which meron yung mga current neuroprotective agents or new cerebroprotective agents natin, and enhancing mitochondrial biogenesis. So again, protecting the mitochondria may interrupt multiple downstream injury pathways in the ischemic cascade. Okay? And again, for neurovascular unit, we want to protect the endothelial integrity, stabilize again the blood-brain barrier, okay, and reduce your MMP activation. Okay? So again, neuroprotective agents, the new generation neuroprotective agents should target the neurovascular unit entirely. Now, in terms of synaptic balance, here, the normal state is excitation, glutamate, NMDA receptor. Inhibition, GABA receptor. And signal integration would be looking at your PSD95 scaffolding. So ang output dapat would be controlled calcium signaling, physiologic nitric oxide production, and synaptic plasticity leading to better survival. So your PSD95 regulates both excitatory and inhibitory synaptic balance, so it converts synaptic activity into cellular response. Okay? So if you look at PSD95, again, it determines the NMDA signaling, which leads to survival or death. Okay, again, it mediates protein interaction. I will show you the next slide with the different PSD receptors. And again, excitotoxicity is not just receptor-driven, but it is scaffold-mediated signaling. Okay, so you can see that, with the PDZ receptors there. Okay, and again, the death signal would be if NMDA and which will affect your PSD95 and increase your neuronal nitric oxide synthase. So during a stroke, there will be excess calcium, which activates your neuronal nitric oxide synthase. Therefore, increase ang nitric oxide, and that can lead to neuronal cell death. So again, the coupling converts normal signaling into a death pathway. So yung ginagawa nating stroke pathway, kahit maganda, pag hindi ma-deliver talaga ng maayos, pwede pa rin magkaroon ng apoptosis yung neurons. No? And here, GABA-A, again, the brain's protective brake, normal function. We know that it's an inhibitory neurotransmitter. It limits your neuronal excitation, and it prevents overload of calcium. Okay? So, loss of inhibition naman can also lead to excitotoxicity. So, stroke, again, is not really just too much excitation. Meron ding problem kapag nabawasan ng inhibition. So again, the synaptic balance should be met. Okay? So if you look at this particular slide here, the GABAergic dysfunction contributes not only to injury but also to impaired recovery after stroke. And restoring inhibition, again, is also important in reducing excitation. So in terms of the paradigm shift, you looking at targeted PSD, again, you preserve NMDA function and disrupt the pathologic coupling. Okay? And if you look at main target, PSD95 and neuronal nitric oxide synthase interaction, yun ang target ng drug. Okay? And result, reduction in nitric oxide, reduction in excitotoxicity, and you're not just focusing on the receptor. Okay? Now, Sanbexin, no, which some of you have already heard, no? Sanbexin is a modern multi-target brain cytoprotective agent. It actually combines edaravone plus dexborniol. So it is, again, designed as a multi-target brain cytoprotective agent. Okay? And again, fast-acting formulation developed as a sublingual therapy. It's being tested now. I think there are some results, clinical trials regarding Sanbexin in the US as well. And again, it aligns with the modern neuroprotection strategy, which is multimodal, mechanism-based, and reperfusion-aware. Okay? So relevant both outside perfusion and a potential adjunct to thrombectomy and reperfusion. Okay? Whether it's including thrombolysis. So here it would be the where the edaravone and dexborniol will act on. Okay? And again, I'd like to show you this particular trials, your TASTE-LA and TASTE-2. So if you look at that, no, they look at TASTE-LA sublingual among patients who were not thrombectomized within 48 hours, given sublingually, and actually the primary outcome was an MRS-021 at 3 months, better for those who were taking Sanbexin versus the placebo. Okay? On the other hand, the TASTE-2, okay, these are the cohorts that have had thrombectomy, okay, given Sanbexin before EVT, okay, and the MRS 022 at 3 months was 55% for Sanbexin and 49.6% for the placebo arm. Okay, so if you translate that, the absolute risk reduction for those who did not have thrombectomy was around 9.7%, and for those who were thrombectomized, binigyan ng Sanbexin before, was 5.4%. For the number needed to treat, 11, okay, for those who were not thrombectomized, so purely neuroprotection lang. If you look at edaravone na walang dexborniol, ang NNT niya is 10, no? Okay? And for TASTE-2, it's 19. So if you look at TASTE-LA, it can be used as a standalone cytoprotective agent, okay, without thrombectomy, which is most of our patients na nakikita natin with stroke. Okay? So this is a new drug, your loberamisal. Okay? So this is targeting both your PSD95 as well as your GABA-A receptor. So here, you can see the dual target neuroprotection, and this is the outcome. Okay? Increased inhibition for GABA, decreased excitotoxic drive for PSD95, and the interaction with neuronal nitric oxide synthase, again, decreased nitric oxide and decreased peroxynitrite. Okay? So in the net effect is it stabilizes the penumbra. I'll skip most of this, but I want you to look at this trial, the LACE trial, okay, which actually is a positive trial, the first positive trial for a neuroprotective agent that was recently published. No? Okay? And if you look at the targets again, PSD 95 and GABA-A, okay, so targeting both these two, okay, molecules or receptors provides a promising strategy for neuroprotection. And if you look at the results here, so intravenous loberamycin 40 milligram dose was given for 10 days through IV infusion, once daily, with around 1 hour ang infusion. Okay, and they follow this patient up at 10 days, 30 days, and 3 months from randomization. And the primary endpoint was functional independence, strictly defined as MRS-021 at 90 days. Okay, I'll just focus on that and look at the results. No, 68% of patients receiving lomeramycin achieved an excellent functional outcome compared to 55% in the placebo group. And this was statistically significant. Okay? And also, highly significant absolute increase in excellent functional recovery. Okay? So, the caveat here is that this study, again, was done among Chinese patients, and it cannot be generalizable at this point in time if you look at scientific perspectives, no? Kasi kailangan mas maraming involved na it should be multinational. Okay? And primary outcome again, yan ang nakita. Number needed to treat is 8. Okay? And again, with this, I think there's really hope that we can use neuroprotective or cerebroprotective agent alone for our patients with stroke, particularly ischemic stroke, kasi hindi nila sinusubukan sa hemorrhagic stroke. Okay? So while mechanical thrombectomy remains now the gold standard for large vessel occlusion, logistical delays and anatomical limitations mean the vast majority, again, of our patients will not receive thrombectomy or they will not be thrombectomized. And here lies the opportunity that we give cerebroprotective agents, okay, that we have in our market. And soon, I think Sanbexin will also be coming into the market in the Philippines by maybe next year. Okay, so hopefully. And of course, loberamycin will be heading for an international clinical trial by next year. So again, with that, I think we have to learn from the past. Okay, here, no? Stroke is a network disease. Timing is critical. Reperfusion has changed the way we look at patients with ischemic stroke. Delivery, manner of delivery matters. Again, let's not forget, it has to be a multimodal strategy. Okay? Hindi pwede yung isang molecule lang ang gusto natin. Okay? And we have to prove that it is effective if these drugs that we are using have multiple or multimodal targets. And again, it has to be an integrated approach, multimodal and precision. Neuroprotection would be our next step. And we hope that, again, that will be part of our search for the Holy Grail. So that is my talk. Thank you and good afternoon.
Thank you, Dr. Johhny Lokin. And now let us welcome our second speaker, Dr. Stephanie Patricia Badillo.
So good afternoon, everyone. I will be lecturing on this topic, remote ischemic conditioning. I would like to thank Dr. Mark Molina, the Vice President of PAVIN and the Scientific Chair of this committee for assigning me this topic. When we were talking about the possible topics that would be presented in terms of neuroprotection, we were thinking of what topics could we talk about that hasn't been talked about before. How could we potentially go out of the box, not repeat what was already previously repeated so many times and maybe explore something new, expand our horizons. So today, this attempts to do that and probably introduce remote ischemic conditioning, or RIC, as a potential innovative but accessible approach, potentially the low-hanging fruit of neuroprotection. What is low-hanging fruit? It refers to tasks, opportunities, or goals that are easy to achieve with minimal effort, representing the easiest wins and most accessible opportunities. So sometimes treatment might not need to be complicated. It could be accessible, universally applicable, technically simple, and it could allow for delivery in pre-hospital or low-resource settings, such as in our country. So today we'll be talking about RIC as applies to that, and maybe, potentially, it could be applied to our existing systems here in the Philippines, especially because it's low resource. So here is an overview of my lecture outline. I have no conflicts of interest relevant to this topic to disclose. So what is remote ischemic conditioning? So henceforth, it will be termed as RIC. It utilizes non-lethal, transient ischemic stimuli in one tissue, typically a limb, either the arm or the leg, to induce profound ischemic tolerance in the distant organ. Historically, it was studied in animals, such as in rats or dogs, and they tried to do it measuring ischemic tolerance in the heart. And then after a certain period of time, the studies then measured its effect on the brain. There are two pathways by which this takes effect. First is the neural pathway, in which sensory afference via cholinergic ganglionic transmission goes from the limb to the target organ or the brain. Then another pathway would be the humoral pathway, in which proteins, interleukins, autocoids are then released to upregulate the synthesis of certain proteins that promote ischemic tolerance. It enables us to reevaluate the paradigm of neuroprotection beyond things that are merely pharmacologic. Again, the mechanism is purely something very simple. It's just applying a BP cuff on the limb of a patient. And using this neural and humoral pathways, synthesizing new proteins that promote ischemic tolerance, we are able to promote neuroprotection or cardioprotection. The appeal in this method is that it's non-invasive, highly tolerable, inexpensive, and potentially universally applicable. How is it delivered in practice? So it's very simple. First, you apply the BP cuff. In certain studies, as we'll see later, the upper limb was most commonly used, and the dosing actually varies. Some studies used the bilateral upper limb, some used bilateral lower limbs. And then the blood pressure cuff is inflated to suprasystolic pressure. Again, the studies used different thresholds. Some used 200 millimeters mercury systolic, some used 220, some just took the baseline systolic blood pressure of the patient and added 100 millimeters mercury on top of that. So it varied. And then they inflated the cuff for 5 minutes to induce brief non-lethal ischemia. The cuff is then deflated for 5 minutes to allow reperfusion. The cycles are repeated for about 4 to 5 cycles per session. Again, the dosing varied. And then this is repeated over several days. Could be given daily or twice daily for days or weeks. So why should we care about this? So because again, this is a simple method. It's cheap and it's non-invasive. As the studies will show later on, it is generally well tolerated among patients. And because it is simple, it has a low training barrier. It is potentially usable in non-hospital settings, such as in the ambulance, for example. Or in the hospital, it could be also used in the emergency department, in the ward, in rehab, or even in outpatient prevention settings. So in one platform or in one modality, there could be multiple use cases. First in acute cytoprotection, and then in chronic neurorecovery or vascular remodeling. How did it shift from a concept to a paradigm? So it was initially studied in 1986, first demonstrated using isolated dog hearts, when they found that brief periods of occlusion to the left circumflex artery in the heart of the dog. It reduced infarct size when that same artery was then occluded for 40 minutes. And then in the 1990s, they were able to demonstrate intra-organ remote protection. So brief ischemia in the circumflex artery, again protected from ischemia, from occlusion in another coronary artery, so the left anterior descending coronary. And then after a few years, 1996, they demonstrated inter-organ remote protection. So ischemia applied to the mesenteric artery in the intestines was found to reduce the size of a myocardial infarction from occlusion of a coronary artery. So this time, it induced ischemic tolerance in a distant organ. And then 1997, there was the limb paradigm, in which skeletal muscle ischemia was found to promote cardioprotection using blood pressure cuff on a limb rather than invasive arterial occlusion. So it was very important that it was demonstrated at the time because inducing ischemia on a limb transiently was obviously less dangerous than inducing ischemia in a vital visceral organ such as the intestines or the heart. So then how did it evolve from paradigm to clinical protection? In 2014, there was the first published clinical proof of concept study showing RIC delivered by paramedics in a pre-hospital setting. And then 2017 came the phase 2 trial demonstrating that 2 weeks of daily chronic RIC before carotid artery stenting significantly reduced the incidence of silent brain infarcts. Further on, 2017, 2018, came about studies exploring its use for vascular dementia and small vessel disease. And then 2022, 2023 came the larger scale trials. So in summary, the physiologic mechanism of this is that the release of humoral factors from the limb that received the ischemic stimulus are released and then goes to the target organ, causing acute and chronic effects. And in the acute window, within 0 to 6 hours of ictus, there is cytoprotection against ischemia reperfusion injury brought about by the suppression of apoptosis and the upregulation of autophagy via intracellular protein kinase pathways. And then the potential for further recovery beyond the acute stroke period could be brought about in the chronic window beyond 12 hours, in which there is de novo protein synthesis, immune modulation, improved endothelial function, and angiogenesis through the increased release of vascular endothelial growth factor and nitric oxide. The concept of RIC is further categorized based on the timing of the stimulus relative to the ischemic event. So you could categorize it in preconditioning, per, post-conditioning. So when you say preconditioning, the maneuver could be applied prior to the onset of ischemia, such as in high-risk patients, for example, those undergoing carotid stenting. So we'll see a study later on that did that. And then for per conditioning, the maneuver would be applied during the acute event, for example, during ambulance transport. For post-conditioning, it could be applied immediately post-event in the acute hospital setting. And then chronic RIC would have standardized repeated application of the maneuver for about 1 week or 2 weeks to leverage the prolonged neurorepair or chronic window mechanism. So again, briefly, just to review, for the preclinical studies, they just demonstrated that RIC repeatedly reduced infarct size and improved long-term neurologic scores, both in the acute period and in the chronic period when they used repeated RIC. But a systematic review published 2024 regarding this cautioned that there may be some publication bias because, of course, neutral or negative animal studies may be underrepresented. And it did have the same findings in terms of neuroprotection for parenchymal ICH and subarachnoid hemorrhage. RIC acting as more of inflammation and recovery modifying therapy, whereas in subarachnoid hemorrhage at the time, there were some early findings that it might be protective versus vasospasm. So what was the actual early clinical experience historically as the trials came along? In Rescue Brain, one of the first trials in 2020, it had a population of about 188 patients with acute ischemic stroke within 6 hours of ictus who received recanalization therapy. And then they gave they gave RIC versus control to these patients. And then the result was, at the time, there was no significant effect yet on infarct volume or MRS. But they did note at the time that further studies were needed due to the small sample size, suboptimal dosing, because they just gave it once. And there may be some confounding variable introduced by the fact that those patients were given recanalization. So it was established to be safe, but efficacy remained vulnerable to timing, dose, and reperfusion status. The next trial was also neutral, so that was RESIST in 2023. So it was a phase 3 trial of 1,500 patients, 700 of which had ischemic stroke, and then 160 had ICH. They applied single limb RIC within 4 hours of ictus, and then they applied it mostly 7 days, twice a day, again, suprasystolic. And the result was that RIC treatment did not significantly result in improved MRS scores, but it was again safe. That no significant differences in the number or serious adverse events. Again, pre-hospital deployment was feasible, but did not yet improve functional outcomes. So which study was positive? So this was the most important one, RECAMIS in 2022. It was the strongest positive phase 3 trial in RIC in acute ischemic stroke. It was also the largest study at 1,800 patients across 55 hospitals in China. They had protocol of applying RIC for patients within 48 hours of ictus with acute ischemic stroke, targeting patients with moderate stroke with NIHSS 6 to 16. And importantly, they excluded those who underwent reperfusion therapy such as IVT and EVT. They gave RIC at 10 to 14 days daily, and they used bilateral upper limb RIC protocol using a pneumatic electronic device for increased compliance. And the primary result was, significantly, patients who were in their experimental arm had functional independence at 90 days, meaning MRS 0 to 1, that was significantly better or had a more likely percentage of this outcome with the RIC group versus that of the control. And as you look at the p-value, the result was statistically significant. So 67.4% more likely to achieve better functional outcomes at 90 days versus 62% for the control. And again, it was safe with no difference in terms of mortality or neurologic deterioration. So the key insight here was that benefit was achieved even without recanalization, and even if the protocol was started up to 48 hours late post-ictus, suggesting that the efficacy of RIC may be towards chronic neurorepair, leveraging that chronic neuroprotective stroke window, not actually ischemia reperfusion protection in the acute stage. This graph or figure just shows us the MRS shift for the RECAMIS trial, in which functional independence at 90 days was found to be more likely in the experimental group or the RIC group versus control, with no significant differences in secondary outcomes, which was defined as early neurologic deterioration at less than 7 days, change in NIHSS scores less than 12 days, stroke or vascular events within 90 days, or mortality. So what made the RECAMIS trial different from all the previous trials that showed neutral or negative results? So I'd just like to highlight that there were key strategic differences in their study design and execution that contributed to its success. First, their patient selection was highly targeted. They targeted moderate ischemic stroke patients with NIH 6 to 16, again within 48 hours, which excluded very mild and very severe cases. Again, they excluded those underwent thrombolysis or EVT, potentially removing confounding variables related to reperfusion therapy. Third, it had the best statistical power and sample size. It is the largest RCT on remote ischemic conditioning in stroke to date, enrolling 1,800 patients. They clearly defined their treatment intensity and duration as bilateral application of RIC repeated over 10 to 14 days, promoting long-term neurorecovery. And lastly, they measured in terms of clinical outcomes, in terms of MRS scores, versus earlier trials that tended to measure surrogate outcomes, such as reduction of infarct volumes or penumbral salvage. So in synthesis, RIC's true clinical utility for acute ischemic stroke may be, as the RECAMIS trial suggested, as a multi-day neurorecovery amplifier for non-perfused acute ischemic stroke patients with moderate clinical deficits, rather than as a pre-hospital adjunct to mechanical thrombectomy, as was in the RESCUE Brain and in the RESIST trials. There are also some studies going beyond acute ischemic stroke. So this RICA trial was a trial on RIC for secondary prevention among patients with intracranial atherosclerosis. So they enrolled 3,000 patients with symptomatic ICAS, meaning those who had recent TAA and stroke. And they did 12 months, quite a long time, of daily bilateral chronic RIC versus control. Their primary outcome was time to first ischemic stroke, which was actually neutral, so it had a neutral result. But their secondary outcome in terms of composite cardiovascular events was actually found to be lower among those who were administered chronic RIC versus control. So it could suggest that among those with risk factors, such as symptomatic ICAS, RIC could potentially be applied to lower the overall risk of cardiovascular events. Just a caveat that in this trial, there was a compliance difficulty, that 46.5% of patients were compliant with the intervention at 1 year. So there was quite a large fall off, which notes that daily chronic RIC, which obviously could challenge patients' compliance. So there should be better measures to encourage compliance and patient adherence in that way. Other studies noted the potential applicability of RIC with regards to carotid interventions. So there was a study by Zhao in China enrolling 189 patients with given 2 weeks of daily chronic RIC prior to carotid stenting. And they found significantly lower incidence of silent infarcts on MRI after 6 months of the procedure. So the outcome here was primarily radiologic. For another study among patients who underwent carotid stenting given RIC was done by Asadi in Iran, but that study was smaller at 74 patients using a single-dose approach. So a single session of RIC was given immediately before stenting. And since it was single-dose, they found no significant difference in silent infarcts among their treatment arm versus control. So the key takeaway here is that inducing ischemic tolerance might require repeated conditioning, as again in the RECAMIS trial, which used repeated conditioning, not a single acute intervention. Now, there are a couple of studies that expand the application of RIC beyond acute ischemic stroke. So there is one trial, the RICH trial, which studied the application of RIC among patients with intracerebral hemorrhage. It was a small study at 40 patients using daily RIC for 7 days. They found increased rate of hematoma resolution, though not a significant difference in terms of hematoma size. And the finding was hypothesized to be mediated by AMPK-dependent immune regulation and anti-inflammatory monocytes. In subarachnoid hemorrhage, we know that there is a risk of delayed cerebral ischemia occurring at days 4 to 14 post-ictus, which might potentially create a temporal window for RIC. And there is an IRVAS pilot study, which enrolled 50 patients with acute subarachnoid hemorrhage, applying RIC during that temporal window. And they interestingly found a reduction in vasospasm, which correlated with improved MRS at discharge. Although, of course, these are small pilot studies. As of now, more larger randomized controlled trials should be done to confirm this. Sharing also potential applications of RIC in terms of vascular dementia and cerebral small vessel disease, small studies actually report that applying chronic RIC over a prolonged period of time, so there was one study which did it for 6 months, actually was found to reduce white matter hyperintensity burden over 1 year, which was again correlated with mild improvement in terms of the MoCA scores, specifically the visuospatial and executive function scores. This remains, again, proof of concept. Studies are small, and follow-up is short for a dementia endpoint since they followed up these patients for about a year. Still, of course, the idea that a cuff-based vascular intervention could modify cognitive trajectory is indeed provocative. So just sharing for this study by Zhao, which was a study on patients with vascular dementia given chronic RIC followed up for a year. On the left side, you see white matter intensities in the RIC group decreased at both day 180 and day 300 follow-ups, whereas on the right side, there was no significant change noted in the control group. So this is just a summary of the clinical trials on RIC. So knowing all that and synthesizing all that, could remote ischemic conditioning be the ultimate low-hanging fruit in terms of stroke neuroprotection? So we have always been discussed neuroprotective drugs, but the greatest hurdle for neuroprotective drugs is the delay in administration and the high pharmacological cost. And as previously discussed, there is still a barrier in terms of the definitive scientific evidence in favor of neuroprotective drugs. In contrast, RIC, if its utility could indeed be established, it could have the potential to bypass both barriers in terms of delay and cost and become an accessible intervention in low-resource health systems. So what could be the future directions for this approach? First is to optimize the dose. Second is to target the population very well. Third is there are also biomarkers being explored for this, such as cerebral blood flow monitoring or proteomic signatures that could be helpful in terms of monitoring the effect. Patient adherence and the use of pneumatic devices could be helpful, and more meta-analysis beyond randomized controlled trials could, of course, be useful to further cement the evidence behind this. So in summary, RIC is a biologically plausible, low-cost, non-invasive neurovascular ischemic conditioning strategy that could be delivered either acutely or chronically, but it is not yet established as routine standard of care for acute ischemic stroke or ICH, subarachnoid hemorrhage, etc. But it could have potential, as shown by the studies earlier, in subacute recovery after ischemic stroke, prevention of stroke in patients with symptomatic ICAS, and possibly protection against subarachnoid hemorrhage vasospasm. But what remains unresolved is the optimal dose, the timing, the target population, and real-world patient adherence. So it is not yet standard of care, but it has growing clinical trial support. It's, of course, clinically feasible and definitely operationally scalable in its simplicity. It might be the next frontier in neuroprotection and is indeed a low-hanging fruit. So this is just an infographic summarizing everything we've discussed. And I'd just like to leave everyone with this simple drawing. So in stroke neurology, a field where our complexity often defines innovation, we have to ask sometimes, what does innovation really mean? It doesn't always have to be cutting edge. Sometimes innovation is about doing things differently, thinking out of the box, thinking about things in ways that are simple, improving our processes in ways that can be accessible yet impactful. Remote ischemic conditioning reminds us that sometimes the most innovative solutions are the simplest ones. Thank you very much.
Thank you, Dr. Stephanie Patricia Badillo. And now let us welcome our third speaker, Dr. Gabriel Alejandro Baroque.
Okay, thank you very much, everyone. Thank you very much to the Academy for choosing me to speak and to in this event, no? The launching of PAVIN. So my topic today is repurposing common therapies, everyday agents with neuroprotective impact. So without saying, I'm not going to be discussing citicoline, edaravone, MLC, all those cerebrolizine, all those medications that we are already geared to giving to patients in with the aim of neuroprotection. Okay, so disclosures, I have nothing to disclose. Okay, so with stroke, of course, standard of care has been discussed heavily for this past 2 days. Thrombolysis, endovascular thrombectomy, and the aim for them, well, to restore blood supply to the ischemic regions in the brain. Okay, this will now halt the effects of the ischemic cascade and downstream cellular damages. Now, I want to look at the thrombolysis and thrombectomy rates here in the Philippines, and I would like to use the study that was published in 2022 by Dr. Collantes, Dr. Navarro, Dr. Gan, and Dr. Belen. Okay, so they looked at the utilization of thrombolytic therapy from 2014 until 2021, and from 1.4%, as you can see right there, from 1.4% from 2014, now it is being utilized in 11%. Now, looking at the government hospital utilization, 7.4%, still pretty low. More so in the private hospitals, 4.8%. They were looking at the percentage of these stroke patients coming into our emergency rooms, and they were looking at the percent of those who got the thrombolytic therapy, the endovascular therapy, or even the combined modalities. And you do see that it is still pretty low. And the main problem here is that we are not able to detect or to bring these patients to the hospitals in time for the golden periods. Okay. So here comes neuroprotective therapy, and it is aimed at the biochemical and molecular events after the ischemic insult. So what we want to do is that we want to stop the irreversible ischemic damage and post-ischemic inflammation. Okay, so there lies our targets. Okay, we have an idea, and piggybacking on all of the lectures that have been discussed today by notably Dr. Villarasa, Dr. Chu, Steph Badillo, and Dr. Lokin, that we are looking at the excitotoxicity, oxidative stress, inflammation, and apoptosis as the days go by after the infarct. Of course, this one-dimensional way of looking at the effects of stroke. No? So we look at the molecular level, and at the cellular level, it's very difficult to discuss, especially with 16 minutes to discuss it. But mainly, we want to stop neuroinflammation, excitotoxicity, and oxidative stress, which all may ultimately lead to neuronal death. So with your blood-brain barrier disruption, leukocyte infiltration, cytokine production, neuroinflammation is produced. Mitochondrial damage, reactive oxygen species production, oxidative stress, and excitotoxicity from excessive glutamate release and reduction, all leading to apoptosis. And that is a very good picture of this. This one is a normal neuronal connection, while this is a neuronal connection in an acute ischemic patient wherein you have excess glutamate. Now, with the glutamate being in excess, you have your NMDA receptors, extrasynaptic, which are overactivated, plus with a influx of calcium. So with this, again, the cascade going to neuronal death. So we're looking at possibilities of preventing this or minimizing this. That's why we look into more common medications. First of which that I was looking at was magnesium sulfate. And magnesium sulfate is usually given to patients with preeclampsia or eclampsia itself. Why? Because of the mode of action Okay, so we have decreased blood-brain barrier disruption, limited cerebral edema thereafter. Okay, then astrocyte, you have, again, with limited cerebral edema. So these are the possible mechanisms. You have your calcium antagonism. You have your aquaporin 4 expression reduction, leading to less cerebral edema. For the neurons, it is an NMDA receptor antagonist, so which we already discussed regarding excitotoxicity. But they were looking at different studies, and the FAST-MAG studies, they also looked into the use of magnesium in stroke patients. You also have the images study, and you have your intravenous mag sulfate in acute stroke studies, randomized clinical trials. Although these clinical trials and meta-analysis have shown that the outcomes do not differ in patients given with magnesium sulfate, they are neutral studies. So I'm not lobbying that we use them regularly, but perhaps consider them given that they are neutral studies. And we have to face it that most of our current neuroprotection medications started out as neutral studies, so they are ever evolving. Okay? Now we know what statins are for, secondary stroke prevention, that has been elucidated by the SPARKLE, the HPS, and the ASCOT LLA studies. Okay? And of course, the guidelines, the American Heart Association guidelines, showing that you have a very strong recommendation for statins as a secondary stroke prevention. However, we also have to know that the statins have the capacity for neuroprotective properties. So you have your endothelial nitric oxide synthase stability, antiplatelet properties, anti-inflammation, decrease in blood-brain barrier breakdown, etc., which leads to neuroprotection, perhaps neuroplasticity. Okay? Now, looking at an article from 2022, this is a systematic review in the use of statins in traumatic brain injury. They looked into 12 studies, and apparently what they have found out is that with the use of statins pre-injury, okay, they saw that there was decreased mortality in these patients, decreased length of stay, and improved Glasgow outcome scale. In the acute phase, you have promotion of cerebral blood flow, decrease in neuroinflammation. In the subacute phase, you have all of these cascades or enzymes that promote or decrease in the level of apoptosis. Then it promotes neurogenesis with all of these factors, VEGF, BDNF, etc. Okay? And they ultimately conclude that statins are able to enhance the Glasgow Coma Scale, survival rates, length of stay, and cognitive outcomes were much better in this study. They were looking at simvastatin 40, atorvastatin 20, and rosuvastatin 20. Okay? Now, diabetes. Anti-diabetic medications, very much studied in the INSPIRES trial. They were looking at the relationship of the stress hyperglycemia ratio and the outcomes that they wanted to see. Okay, so you have their efficacy outcomes and safety outcomes. They found out that there was elevated stress hyperglycemic ratio. It was independently associated with increased risk of stroke recurrence, composite cardiovascular events, ischemic stroke, poor functional outcomes, and early neurological deterioration. Okay? So looking at the anti-diabetic medications, first class of them will be your GLP-1s. This is personified by your Ozempic, your semaglutide. But of course, there are other classes of other types of medications under this class of anti-diabetics. You have your tirzepatide, liraglutide, and dulaglutide as well. And of course, we want to find out what their mechanism of action is. And the proposed mechanism of action would be to modulate the inflammatory response, to stabilize the endothelium, and to proliferate your M2 microglia, which will now promote neuronal repair. Okay? So how can we test this theory out? Of course, a systematic review or meta-analysis should be looked into. And this is a fairly new article that was published in 2026, this year. Okay? So they looked into 31 studies, preclinical studies, and 4 clinical studies, which had animal and human subjects. And the outcomes that they wanted to find out was that if there would be neurological improvement, infarct size reduction, and mechanism of, and look into the mechanism of action. And you have with your GLP-1s, the medications right here, and overall they concluded that your GLP-1 agonists are able to reduce the infarct size and improve the neurological deficits in animal models. Of course, animal models, not yet for human consumption. But again, the mechanism of actions that they were looking into, decrease in oxidative stress, decrease in cell death, and decrease in inflammatory response. Another class for your anti-diabetics will be your SGLT2 inhibitors, and with decreased glucose, they were looking at these mechanism of actions. You can have atheroprotection, you can have decrease in glucotoxicity, decrease in inflammation, increase in BDNF, decrease in oxidative stress. Okay, so there's also a possibility for cognitive improvement, which was elucidated earlier in the dementia module. Okay, so here in this 2021 study, they were looking at it is a systematic review and meta-analysis of SGLT2 inhibitors to reduce the risk of cerebrovascular and cardiovascular outcomes. And all across the board, it was an intention to treat study, and this study concludes that there is a significant reduction in the hazard for stroke in patients given SGLT2 inhibitor compared to your DPP4 inhibitors and non-SGLT2 inhibitors. So all across the board, it seems like it is very promising. Going into psychiatry, well, in mood disorders specifically, and some psychotic disorders, there would be inflammatory changes, there could be structural changes inside the brain as well. And here, we see that we have our SSRIs, and it modulates your GSK3 pathway, which once modulated, decrease in activity, you can provide synaptic plasticity and neurogenesis. Not only that, you can also look into lithium as for possible neuroprotective properties. However, lithium has a very narrow therapeutic window, and it's very difficult to titrate up or down depending on the lithium levels of the patient. Okay, so since your SSRIs are apparently easier to use, well, they were looking with the FLAME study. They were looking at fluoxetine and its effect on stroke patients. Same with the FOCUS trial, the effects, and the AFFINITY trial. All of these trials were proven to be neutral. Okay, this newer article from 2026 looked into the effect of antidepressants, different antidepressants, and how it affects the motor scales for the Fugl-Meyer, the Barthel Index, and the modified Rankin scales. And they were looking at different antidepressants with fluoxetine and citalopram, although selegiline was also used here. You can see that this is for the Fugl-Meyer motor scale scores, and the changes from baseline to the outcome were apparently favoring antidepressants. Okay, see right there. Now for the Barthel Index, again, they are favoring fluoxetine, your escitalopram, although your citalopram is not significant, but all in all, they were favoring the use of antidepressants. Okay? And same with your modified ranking scale, specifically for citalopram. So there's a possibility, there's a plausible factor for your antidepressants. And I have come across this newer study which is still ongoing. They are looking at completing the study in 2027. It's called Protocol for Escitalopram and Language Intervention for Subacute Aphasia. So the ELISA trial. It is a randomized, double-blind, placebo-controlled trial. So we are very excited to see if we can further enhance our neuroprotective strategies. This study is being done in Johns Hopkins University. Okay? Here we have colchicine. Okay, so they were looking at colchicine for possible neuroprotection, and it looked into in vitro and in vivo models, and they were looking at the mitochondrial pathway, the MAPK pathway, inflammation and apoptotic pathways, and they were able to see that there's a promising data regarding colchicine and neuroprotection. Okay, so last study that I would want to show you would be neuroprotective agents in acute ischemic stroke. This was published in 2022. Okay, so I'm just going to be highlighting those molecules that have potential neuroprotective properties. So here we have verapamil, your calcium channel blockers. Okay, so earlier excitotoxicity, you have increase in calcium influx. No, so you have the verapamil, nimodipine, then your immunomodulators to modulate your immune responses with natalizumab. Then you have your antibiotics with imatinib and minocycline. N-acetylcysteine is apparently it has a positive study. Uric acid, okay. Albumin, although this was already discussed by Dr. Lokin. Glibenclamide, hypoglycemic agent. Okay. Then your statins, we have already discussed that. Theophylline, GTN, dapsone, perhaps has a role in anti-apoptotic pathways. And of course, your NMDA receptor antagonist with your neranitide, which was discussed earlier as well. And your memantine, NEU 2000. This is the one, it is an ongoing trial. Okay. Magnesium, we have already discussed that as well. Okay. So to end my lecture, I just want to give you a take-home message that stroke care does not end with reperfusion. While thrombolysis and thrombectomy restore blood flow, the ischemic cascade continues to evolve at the cellular level. So we wanted to these repurposed, widely available therapies. They target key mechanisms such as excitotoxicity, oxidative stress, and neuroinflammation. Even when clinical trial outcomes are neutral or evolving, these agents offer biologically plausible, accessible opportunities to enhance neuroprotection, especially where advanced stroke interventions are limited or delayed, and that the future of stroke care lies not only in recanalization, but in strategically layering neuroprotection onto existing systems of care. So with that, I would like to say thank you.
So we extend our appreciation to the three speakers for sharing such forward-looking and thought-provoking lectures on cerebroprotection. So we learned that cerebroprotection invokes multiple molecular targets, and thus it would entail multimodal treatment strategies. But the drugs in the pipeline are not readily available and are not affordable. So we can try remote ischemic conditioning. It is a cheap, practical approach, which we are actually doing at bedside, but there is a need for local studies. And we also had a review of all the drugs that we can use, even drugs that are being utilized for stroke comorbidities like statins, anti-diabetes, and antidepressants. So in the interest of time, we will not entertain questions anymore. You can just approach our speakers if you have some questions. Our heartfelt thanks go to the speakers for their thoughtful answers and to our audience for staying. And as we close this final plenary session, let us carry forward the knowledge and inspiration gained here to guide future innovations in stroke medicine. On behalf of the organizing committee, I thank our distinguished speakers and all of you for being part of this journey. May you continue to enjoy the rest of the evening. Thank you.
Thank you to our speakers, Dr. Johhny Lokin, Dr. Stephanie Patricia Badillo, and Dr. Gabriel Alejandro Baroque, and to our moderator, Dr. Maria Socorro Sarfati.